accepted as the 18 months. It was given by Muck T et al. And Lin HC et al., where they defined early recurrence to be less than 18 months, whereas more than or 18 months was considered as late recurrence. Early recurrence, as can be seen from these Kaplan-Meier curves, show that 5-year overall survival of patients who developed early recurrence had worse prognosis when compared to late recurrence. Similarly, the overall survival of the patients at 5 years after a definite treatment for the recurrence was also poorer for an early recurrence when compared to late recurrence at 20.5% and 42.3%, which was statistically significant. Over time, there have been multiple survivor predictor scores which have been given by Yu et al., Lacey et al., and Tam et al., but none of these have been validated externally and hence have not been routinely practiced. Now, once that we have gotten a background for what a recurrence is and its prognostic factors, we should know the pattern of recurrence to decide upon the treatment options. It can be a local recurrence, which is most common, a regional recurrence, a loco-regional recurrence, or can have distant metastasis. Most of the recurrence, that is 2/3, occur within 24 months of the completion of the treatment for the primary tumor. Hence, follow-up should be very vigilant for the first 2 years. Certain challenges are seen in the presence of a local recurrence due to the prior treatment, whether surgical or whether it is radiotherapy or chemotherapy. These include the extent of the previous surgery and or radiation, the presence of a previous flap, the changes in the anatomical orientation. Even if the lesion is diagnosed early, it can possess complications for resectability, also for evaluation. In a recurrent tongue cancer, if there is presence of extension to the base of tongue, this leads to a morbid resection, which can lead to a poor quality of life. In a recurrent buccal cancer, presence of involvement of the masticator space, especially supramandibular notch disease, makes resection more complicated. This is because of proximity to vital structures. The presence of perineural invasion leads to multicentric spread, which causes remote recurrences. And this requires a thorough and meticulous assessment. The regional recurrences is most commonly occurs in the level 2 cervical lymph nodes, followed by level 3, level 4, and level 5. Uncommon sites include the intraparotid, the prelaryngeal, and the retropharyngeal sites. The success rates post-salvage surgery have been seen to be 21.7% for uncommon sites versus 68.8% for usual regional recurrence sites. Again, in this Kaplan-Meier curve, it can be seen that the 5-year disease-specific survival for usual sites of metastasis, that is regional recurrence, is much better at 60.8% versus 23.8% for unusual sites of metastasis. The 5-year overall survival compared between the local recurrences and the regional recurrences was done by 2 studies, that is the Sessions et al. And Muck et al. Sessions et al. Had 47% recurrence rates, which consisted of 34% local recurrence and 31% regional recurrence. Whereas Muck et al. Had an overall recurrence rate of 23.9%, which consisted of 64.9% local recurrences and 25.1% loco-regional recurrences. In this, it can be seen that the 5-year overall survival for those who had local recurrence was 48.6% and 37.5% when compared to those who had regional or loco-regional recurrence, which was 30.5% and 21.5%. Hence can be concluded that local recurrence has a better 5-year overall survival when compared to loco-regional recurrence. Now, once we understand what a recurrence is, the factors, the prognostic factors, and the pattern of recurrences, we have to come to the evaluation and the management for the recurrences. Before the evaluation, it should be important that there should be a proper follow-up protocol which should be followed. The most commonly utilized is the NCCN guidelines, which suggests a follow-up of every 1 to 3 months for the first year, every 2 to 6 months for the second year, every 4 to 8 months from year 3 to 5, and yearly for more than 5 years. Once the patient is on follow-up, a thorough examination should be done at every follow-up. A clinical examination post-treatment is always challenging because of pain, trismus, edema due to the previous surgery or systemic therapy or radiotherapy, the radiotherapy and chemotherapy changes, residual ulceration of the tumor necrosis, and osteoradionecrosis. The presence of persistent pain is most important symptom to suspect a recurrence. Endoscopy is important today, especially to diagnose cases where pain, trismus, or other changes are seen and clinical examination is difficult. Imaging like CT, MRI, and PET can be done, which I will be discussing. To confirm the recurrence, a biopsy is a must. Preferably, it should be done 12 weeks after the radiotherapy. This is to prevent false negative results due to a residual ulceration of tumor necrosis, and also to prevent non-healing of the biopsy site due to radiotherapy changes. But if there is a high level of suspicion and if the lesion is persisting, then biopsy can be done even before 12 weeks. Examination under anesthesia is extremely important, especially for recurrent tongue lesions which are extending into the base of tongue. Endoscopy, there is no much role for pan endoscopy when it comes to an initial workup, because the synchronous second primary is only occurs in 3 to 4% of the cases, whereas metachronous second primary occurs in 9 to 10% of the cases. There are newer endoscopic techniques like narrow band imaging, which helps in detecting second primary as well as recurrences much earlier. Coming to the imaging modalities, the PET scan has 100% sensitivity and a high negative predictive value, which helps in the early detection of occult neck metastasis and micrometastasis. But the PET scan has a low specificity to differentiate between a residual tumor and a post-RT change. The conventional MRI has 100% sensitivity, but has distorted images. A diffusion-weighted MRI has a higher specificity and also helps in the proper anatomical imaging. A CT scan has high sensitivity of 75% and helps in the differentiation between a residual disease and post-op changes. It also has high sensitivity for detecting extracapsular spread. There have been certain criteria which have been given to evaluate the neck disease or the regional recurrence in imaging. One such is Hopkins criteria, which is a 5-point score to evaluate and differentiate between post-radiation inflammation and a residual or recurrent tumor. In this, a score 3 likely presents a post-radiation inflammation. A score 4 suggests a likely residual or recurrent disease, and a score 5 shows a residual or a recurrent tumor. Just like BIRADS and TIRADS, there is also NIRADS, which is neck imaging, reporting, and data system. This also helps in diagnosing a regional recurrence. If NIRAD's score is 0, then there is incomplete diagnosis, and it requires prior imaging examinations for comparison. If NIRAD's is 1, there is no evidence of recurrence and routine follow-up is suggested. If NIRAD's is 2, then there is low suspicion for recurrence and a regular follow-up with regular interval imaging is required. If NIRAD's is 3, then there is high suspicion for recurrence and the lesion should be biopsied. If NIRAD's is 4, it is a known recurrence and definite treatment should be started. Now coming to the management of recurrent disease, NCCN guidelines divides the recurrence or persistent disease in locoregional and distant metastasis. If the disease is locoregional without prior radiotherapy and if it is resectable, then surgery with or without adjuvant treatment should be given. If the locoregional recurrence is unresectable, then concurrent systemic therapy or radiotherapy or a combination systemic therapy should be advised. If the lesion is unresectable, then re-radiation with systemic therapy or best supportive care should be suggested. If the patient has locoregional recurrence and have received prior radiotherapy and is resectable, then surgery with or without post-operative adjuvant therapy should be advised. If the lesion is unresectable, then re-radiation with with or without systemic therapy or systemic therapy of best supportive care should be advised. If there is presence of distant metastasis, then palliative systemic therapy or best supportive care should be advised. Coming to surgical management, certain indications are present for a salvage surgery. These include local or locoregional recurrence for early T1 and T2 oral cavity cancers, that is a primary cancer. These should have received a single modality treatment, either surgery or radiotherapy. Isolated recurrences in the neck where the primary has been treated but the neck has not been addressed or it has received only a single modality treatment. Neck recurrences which follow a definitive treatment in the form of either radiation or chemoradiation and the neck has not been dissected, and when the surgery is not functionally morbid. Absolute contraindications for surgery include the involvement of the pterygopalatine fossa with cranial neuropathy, gross extension to the skull base, more than 270-degree encasement of the common or internal carotid artery, the direct extension to mediastinal structures, prevertebral fascia or the cervical vertebrae, presence of subdermal metastasis, nasopharyngeal or brachial plexus involvement. Nowadays, involvement of the pterygoid muscles and the extension of neck disease to involve external skin have become relative contraindications because of better surgical techniques and reconstruction available. Now, what is the outcome of a salvage surgery? Is it important? According to a review article done by Ho A.S. et al., it can be seen that both the median survival as well as the 5-year overall survival for salvage surgery with or without adjuvant therapy was much better when compared to patients who received re-irradiation with or without systemic therapy or systemic therapy alone. According to this, it can be concluded that salvage surgery has the best opportunity for locoregional cure and control when compared to chemotherapy or radiation alone. Before taking the patient for surgery, it is important to evaluate the nutritional status of the patient and decide upon whether the patient requires any alternate feeding methods like a PEG, a feeding jejunostomy, or a long-term nasogastric tube. Almost 40% of the patients who have undergone radiation or chemoradiation previously develop hypothyroidism. This leads to defective wound healing, and hence it is important to correct the hypothyroidism and make the patient euthyroid before the surgery. Hypoalbuminemia is an important prognostic factor which also which affects the wound healing, and this is a very neglected factor, especially in the Indian scenario. Just like the primary disease, even in recurrence, there are certain important considerations during surgery. These include the presence of a positive surgical margin, which is the single most important predictor for poor prognosis. This can be seen in this Kaplan-Meier curve, where a close or a positive surgical margin has a worse survival when compared to a clear margin. Hence, it is important to use frozen section if available in the institute to evaluate the margins intraoperatively. It should also be known that the tumor has a pattern of shrinkage, especially tumors of the tongue, where almost 40% shrinkage is anticipated. Reconstruction has to be planned prior, and a more than required reconstruction should be planned for the excision. Due to the submucosal extension or the skip lesions, the histological accuracy for the assessment of adequate surgical margin is only 50%. The tumor margins become more fibrotic and scar if radiation or chemoradiation has been given, which makes it more difficult to assess, and a wider surgical margin should be taken. In a salvage setting, a minimum of 1.5 centimeter margin should be taken when compared to a 5 millimeter margin in a primary resection. Coming to the primary, that is the local recurrence primary lesion. As in a primary disease, incision can be a midline lip split or an angle split incision. Midline lip split incision is given when the lesion is located away from the oral commissure. It has a better oral competence and is better for cosmesis. If the lesion is close to the commissure, in order to avoid the devascularization from the midline to the oral commissure, it is better to give an angle split incision. Angle split incision is also preferred when adjacent skin excision is required. If the recurrent lesion is in the tongue, and if it is very superficial or if it is very small, then a partial glossectomy can be addressed. But most of the times, in the tongue lesions, there is a early longitudinal migration which causes involvement of the mylohyoid muscle, and hence a compartmental hemiglossectomy is preferred. If the lesion is larger and if required, a subtotal glossectomy or a near total glossectomy can be done. Coming to mandibulectomy, as we all know, there are two methods for mandibulectomy usually, a marginal mandibulectomy and a segmental mandibulectomy. In patients who have a large tumor or who have undergone radiation prior in recurrent settings, then a segmental mandibulectomy is preferred over a marginal mandibulectomy. This is because most commonly the recurrence will be multicentric and can have multiple breaks in the periosteum. There is higher risk for osteoradionecrosis for patients who are planned for re-irradiation. In certain settings where the disease is away from the mandible and is small, marginal mandibulectomy can be done, but during reconstruction, it should be completely covered by a flap. This is to prevent osteoradionecrosis during re-irradiation. Coming to a supranotch versus infranotch disease, the study conducted by Lao CT et al. divided the patients into supranotch and infranotch disease based on CT and MRI. In this study, it was seen that the 5-year locoregional control and survival was much better for an infranotch disease when compared to a supranotch disease. Along with this, if there was a presence of pathological N0 or N1, it had a better locoregional control and survival at 5 years when compared to a pathological N2 neck. This was seen in the infranotch disease. If there was nerve invasion, even in the infranotch group, then it had poorer survival and also poorer outcome for recurrence. Coming to the neck or the regional recurrence, while addressing the neck, it is important to give the incisions preferably without trifurcations. This is because there is higher risk for wound dehiscence, abscess formations, and gaping, especially during re-irradiation. The neck will have thin skin and atrophied platysma. It is difficult to dissect the planes because of excessive adhesions, which has an increased risk of injury to the nerves as well as vessels. A simple pectoralis myocutaneous flap coverage for the vessels should be planned in a radical neck dissection. According to a study done by Jones AS et al., the 5-year survival for patients who underwent radical neck dissection was 31%. According to a study done by Schultz P. et al., the perioperative mortality was double when it came to salvage surgery when compared to primary surgery. The postoperative complications included wound dehiscence, infection, abscess formation, hemorrhage, including carotid blowout, orocutaneous fistula, and flap failure or necrosis. According to the post hoc analysis of a phase 3 RCT done by Patil VM et al., 113 patients had residual or recurrent disease and were divided into 2 groups that were willing for salvage surgery and unwilling for salvage surgery. In this study, it was seen, according to this Kaplan-Meier curve, that the overall survival and the median overall survival was much better for patients who were willing for surgery at 22 months when compared to 9.7 months for patients who were unwilling for salvage surgery. This is the only prospective data that is available in the Indian setting. Due to the limitations in reconstruction, in the 1970s, only 18.3% of recurrent oral and oropharyngeal tumors were surgically salvageable. But nowadays, because of the advances in the microvascular techniques as well as the free flap reconstructions, success rates are almost more than 90%. Selecting an appropriate recipient vessel for the neck for the reconstruction is crucial for a successful outcome. It has to be anticipated that the recipient vessels can have spasm or have anastomotic complications due to inadvertent injury because of difficult dissection. In this reconstructive ladder, it can be seen that most commonly, especially for salvage surgery, a free tissue transfer should be planned. If not possible, then a local tissue transfer can be planned, but it should be away from the region of radiotherapy that has been previously given. According to Affodale et al. Study, any free flap failure increased based on sequential reconstructions. The most common flap that was done was the anterolateral thigh flap, and even free fibula flap was done at first recurrence, especially if resection involved bone. The microvascular anastomosis can be planned for the contralateral superior thyroid or facial vessels, or ipsilateral superficial temporal or transverse cervical vessels, especially if the ipsilateral neck has been addressed previously. Now, coming to the adjuvant therapy post-salvage surgery, it has been seen that it has better outcomes in RT-naive patients when compared to patients who have received RT prior. According to Mizrachi et al., 15% regional recurrence was seen in their study, out of which 87% underwent salvage treatment. Salvage surgery with adjuvant therapy had a better disease-specific survival when compared to only salvage surgery or non-salvage surgery cases. A phase 2 RCT done by Janet et al. Divided the patients into two arms consisting of re-irradiation concurrent with chemotherapy post-surgery versus observation post-surgery. There were 65 patients in each arm. As can be seen in these Kaplan-Meier curves, patients who received adjuvant therapy had better locoregional control when compared to the patients who received no treatment or were only on observation. Similarly, disease-free survival was also better in chemoirradiation patients when compared to no treatment, but the overall survival was not statistically significant between the two groups. Coming to the survival after salvage surgery, in radiation-naive patients, it was seen that 5-year overall survival was 74%, 5-year recurrence-free survival was 60%, and 5-year locoregional control rate was 59%. As in the primary setting, presence of extracapsular spread, tumor thickness of more than 10 millimeter, presence of lymphovascular or perineural invasion had worse prognosis. A short note on recurrence, re-recurrence. 50 to 60% recurrent oral cavity and oropharyngeal tumors had a greater risk for re-recurrence after salvage surgery. If the second recurrences occurred within 6 months, then the 3-year cancer-specific survival was 0%, and hence these patients were considered for palliative intent management. Second salvage surgery can be done, especially for motivated patients with good performance state and if the DFI is more than 6 months. According to the EORTC QLQ C30 and head and neck 35 based quality of life assessment, it was seen that the global quality of life drastically dipped at 3 months, but it recovered at 1 year. The worst affected was swallowing and speech. On the other hand, pain was seen to reduce drastically at 3 months and it remained below baseline at 1 year. The role of radiation or re-irradiation. The indications for radiotherapy is the same as the primary setting, which included a depth of invasion of more than 10 millimeters, close margin, presence of a T4 disease, and nodes more than 3 centimeters. Re-irradiation increases both the acute as well as the late toxicities. But with newer techniques like intensity modulated radiotherapy and volumetric modulated arc therapy, there are lesser adverse effects. If recurrence occurs within 6 months of receiving more than 50 gray of total radiation, it is considered a radio-resistant tumor, and survival is questionable in these patients. Most preferred is giving re-irradiation after 2 years for the maximum benefit. But if it is required, there are certain studies which suggest that radiotherapy can be given at 1 year post previous radiation, but it is never given before 6 months. Management of oligometastatic disease. 1 to 4 metastatic sites is considered as oligometastasis. Lung oligometastasis is the most common, and the treatment of choice is pulmonary metastasectomy. This was seen in the study done by Handy J.R. et al., where he divided the patients who underwent resection and who received chemotherapy. It was seen that median survival was 19 months versus 5 months, and the 3-year overall survival was 68% versus 15%. Coming to the management of the recurrent unresectable or metastatic disease. There are certain key factors which have to be considered. These include the original chemotherapy that has been received by the patient, the response to initial chemotherapy, the interval between the initial treatment and the disease progression, the patient performance status and the comorbidities, exposure to immunotherapy, and also financial and social factors. It was seen that if platinum-based chemotherapy was given initially, and if the disease recurred within 6 months, it was considered to be a platinum-resistant tumor. Hence, platinum-based chemotherapy was not given after the recurrence. The approach to systemic therapy is complex, but it should be remembered that initially immunohistochemistry for PD-L1 should be first done. If the combined proportion score is more than 20, then a single agent immunotherapy like pembrolizumab can be given. If it is less than 20, then chemotherapy with or without immunotherapy can be given. If the CPS score is more than 1 and it has a rapidly progressive disease, then chemotherapy along with immunotherapy can be given. If it is not progressive, then a single agent immunotherapy can be given. If the CPS score is less than 1, then chemotherapy with or without cetuximab can be given. Immunotherapy can be given in this setting, but it does not have much effect. The EXTREME trial evaluated the addition of cetuximab to chemotherapy. In the EXTREME trial, as can be seen from these Kaplan-Meier curves, the patients who received chemotherapy along with cetuximab had a better overall survival when compared to patients who received only chemotherapy, with a median overall survival at 10.1 versus 7.4 months. The progression-free survival was also better for patients who received chemotherapy with cetuximab at 5.6 months versus only 3.3 months for patients who received only chemotherapy. According to the phase 3 RCT, Checkmate 141, they divided the patients into who received single agent nivolumab versus patients who received chemotherapy. In this, it can be seen that the overall response was much better, that was 13.3 in single agent nivolumab group when compared to 5.8 who received only chemotherapy. In this graph, it can be seen that the median survival was 7.5 months for nivolumab single agent versus 5.1 months for chemotherapy with a hazard ratio of 0.7. Coming to Keynote 048, this evaluated the role of pembrolizumab in recurrent or metastatic or unresectable head and neck squamous cell carcinoma. They had 3 arms. The first had pembrolizumab monotherapy, second was pembrolizumab with chemotherapy, and the third had extreme regimen. The results of this trial was that overall survival was seen to be much better for patients who received either single agent pembrolizumab or pembrolizumab with chemotherapy when it was compared to extreme regime. This was seen in both patients with PDL1 CPS more than 20 as well as PDL1 CPS more than 1. In a LMIC like India, it is very important to have affordable standard of care in this setting. A randomized phase 3 trial by Patil v. et al. Compared oral metronomic therapy, which consisted of methotrexate and celecoxib, with cisplatin-based chemotherapy. As can be seen from this Kaplan-Meier curve, the patients who received oral metronomic chemotherapy had a better median overall survival at 7.5 months versus 6.5 months for intravenous cisplatin-based chemotherapy. The 6 months overall survival was 62% versus 51%. The 6 months progression-free survival was also better in patients who received oral metronomic therapy when compared to chemotherapy. To summarize the systemic therapy, in simple terms, the options available are chemotherapy with or without immunotherapy, chemotherapy with or without cetuximab, chemotherapy alone, and immunotherapy alone. Now, to summarize the entire management of recurrent oral cavity cancers, firstly, follow-up is very crucial. During follow-up, if we suspect a recurrence, a thorough evaluation should be done, clinical, endoscopic, as well as imaging. If there is high level of suspicion, then a biopsy should be carried out. Once the recurrence is confirmed, the patients are divided into local, loco-regional, and distant metastatic groups. If the patient has a good performance status, if the patient has local or loco-regional disease, performance status, prior treatment history, and the disease-free interval should be assessed. If the patient is a surgical candidate, after multidisciplinary team discussion, patient can be planned for salvage therapy with or without adjuvant radiotherapy or chemoradiotherapy. If the patient is not a surgical candidate or is not willing for surgery, then definitive chemoradiation or palliative systemic therapy or best supportive care can be offered. If the patient has distant metastasis, then palliative systemic therapy or best supportive care can be offered. Thank you.
Thank you. Thank you, Dr. Gitanjali. I think you have done a wonderful job and you have done it you have covered most of the things and you have done it very thoroughly. Uh, with a few points I would like to make about that you mentioned is management of isolated lung mets, which you said in one of the studies they have found that outcomes are good. So the problem is in patients who present with us with on follow, and we do imaging and we found isolated lung metastasis there or is a second primary. It's very difficult to confirm it. So it is a institutional protocol. It's not that always we go for a surgery for all these patients. Because we don't know whether it's a METS or whether it's a second primary. So we have to consider many factors, discuss with the patient attendant because surgery is an invasive procedure, and some patients can go for only SBRT even. So these things are not standardized, but one can practice them only
जी,
when we have multidisciplinary team, protocol
हाँ,
management.
5 मिनट
Then only you can consider treatment like that. Another thing which Tata has come up is a low dose immunotherapy regime, which is not standard of care in Western countries, but it might benefit our country because cost is prohibitive when we are using immunotherapy. I think Dr. Divan, any comment, sir? I think she has done a wonderful
I
job. That's
think
what I can say. Yeah,
simply superb
yeah,
coverage of the
yeah.
topic, simply superb and very good slides. A
Thank,
difficult topic, but very well presented.
thank you, sir.
Hats off to you, Gitanjali. Well done.
Thank you, sir.
And just, I think, could you say something about proton beam therapy role?
Hmm. I'm not sure, sir. For recurrent disease, I'm not sure.
This is the situation when there is a role for re-radiation with proton beam therapy. Is one of the indications. Okay.
Some of the sites where you need to save the structures, like spine is there. That these areas, it's very, matlab, it's where proton really helps there.
Okay, sir.
Anything in the chat box?
So I'm not able to see anything.
No. But wonderfully covered, Gitanjali. I must compliment you and your guide also, Mudit. Very well
Yes.
covered.
Thank you,
Thank
sir.
you, sir.
Thank you.
Okay. Thank you, sir.
हाँ
Bye.
जी, नवनीत जी।